right. Welcome everybody to the May edition of the DuPage ROSC presentation series. My name is Jared Burton. I am the coordinator of the DuPage ROSC. Glad to be here with everybody again, as per usual. For those of you who maybe are here for the first time for one of these presentations, this is an opportunity we take once a month on the third Wednesday of every month to kind of dig a little bit deeper into a topic along the continuum of substance use and mental health. If you attend our usual council meetings, you know that sometimes the amount of time we have to dedicate to guests is a little bit shorter with all of the information we got to pack into those meetings. So this is just a time we have, a solid hour just to be able to get some presentation and then have some conversation as well at the end. If I could start by asking everybody to please mute their microphones so we can cut down on any interruptions during our presentation, that would be super helpful. And then if you want to put your name and contact information into the chat, so we can take some attendance and make our friends at the state happy by submitting that. So I've got a few housekeeping things before we get into our presentation. So I'm going to go ahead and share my screen, and then we'll go over a few things, and then we will get started. All right, somebody give me a thumbs up if you can see it. I got a thumbs up. All right. So just a few meetings and stuff to go over. Our next ROSC Council meeting, proper ROSC Council meeting, will be on Wednesday, June 12th at 3 p.m. June, we're going to be talking about our substance use and mental health challenges and treatment options, specifically for first responders. So if you aren't aware, first responders sometimes have a need for specialized services when they themselves are seeking treatment or therapeutics. We have a person on staff with us, our outreach coordinator, Josh Rich, who he himself is a former first responder, and he does a lot of work with helping other first responders with their treatment options. We are also, I'm just waiting on a final confirmation, but we actually will have a first responder on site too to talk about their own experiences. So that should be a good one. Those meetings are always hybrid. So you got the option of being on Zoom or with us in person at Serenity House. Those of you who have attended, I never change that Zoom information. So if you're ever like scrambling for a link or a Zoom login, if you have it from the last time you went, it's going to stay the same. So hopefully you can join us on Wednesday, June 12th at 3 p.m. for that one. ROSC in the past few months has started to provide trainings that offer CEUs free of charge to the community. We make sure everybody is muted. That would be great. Coming up, the next one, Wednesday, May 29th, so that's at the end of this month, we're going to be talking about verbal de-escalation skills in a treatment setting. This is, I can say personally, a blind spot for me. I have not taken a training like this previously, and those of you who have, maybe you could treat this as a brush up. These are all in person. So on the 29th, we will have that at Serenity House from noon to 2:30 p.m. As you can see, we have 2.5 CEUs that we're offering for people who attend. If you want to take a screenshot, the number is up on the screen, or you can just reach out to me after the meeting, and I'd be happy to get you set up and registered for that particular training. This month, until the end of May, we will be continuing our Veterans Memorial Drive. About every quarter, DuPage ROSC tries to do some kind of collection drive for community partner sites. Previously, we've done collections for People's Resource Center, Teen Parent Connection. This time it is for our friends at the Midwest Shelter for Homeless Veterans. If you were at our last ROSC Council meeting, we had a nice presentation from the folks at Midwest Shelter. They always have a list of things that they could use on site. And as you can see, I kind of put them up there. So household items, kitchen items, linens, cleaning supplies, toiletries, and clothing and winter items. I went and made the first of what seems to be many drop-offs already, and I took about 10 full bags of clothing, toiletries, and other items and dropped those off last week. I have about another 10 bags in my closet, and between you and me, I cannot afford the closet space, so I'm gonna have to make another drop-off later. But I'll continue to collect stuff through the end of May. You can always drop things off at Serenity House in Addison, or you can contact me to make arrangements. I just want to say to those people who have donated stuff already, you guys always come through amazingly. The amount of stuff we've been able to drop off for partner sites previously is just, to me, it's astonishing. So it shows me that we have great partners and people in the community who are engaged in helping these partner sites when we make these drives. So if you got some stuff, check your closets, and I would be happy to take that stuff off your hands for DuPage County veterans. This Saturday, DuPage ROSC and the Serenity House Alumni Group, we are having a taco fiesta. $5 entry fee for all you can eat. That's going to be here at Serenity House from 5 to 7 p.m. We already started buying the supplies. Really, really looking forward to this one. There is a $5 entry fee. However, just want to let everybody know that money, all of that goes towards the Serenity House Alumni Fund. So that's for folks who have come through as clients of Serenity House. Building alumni networks is really important. This is a way to keep people connected. Once we leave treatment or sober living or whatever it is our particular situation is, it's important to stay plugged in with the community. It's important to build that sober network around us. And so being able to put on an event like this is really great because we can bring those people back and have like a good evening of fellowship. So this is open to the public. If you're looking for some amazing tacos, all you can eat, come and join us on Saturday. Last but certainly not least, just a couple of upcoming meetings and trainings I don't have flyers for just yet. The next ROSC presentation series, which again is the third Wednesday of every month. Next month, I am actually going to be presenting on a topic I've been trying to wrangle for a few months as far as like a specific topic. But it was something I noticed when going into a vape shop recently, which was kind of being blown away by the amount of things that are on offer there that people are using to get high. And this is by no means any type of accusatory thing for the people that use that. Obviously, person-centered, everyone's approach is different to this stuff. However, there are a lot of things being sold at your average vape shop that can be particularly dangerous. So whether that's kratom, whether that's stuff like tianeptine. Recently, I saw a vape shop that was selling nitrous oxide canisters. So this is all stuff that you can buy in a shop. And if you're like me and you're out here in DuPage, there is a vape shop like every other block. So I think it's important to kind of talk about, what's being sold, especially towards younger groups, so adolescents and, early 20-something. So come back for that one on the 19th. Lastly, on Friday, June 24th, from 9 a.m. to 2 p.m. Here at Serenity House, Dr. Aaron Weiner was going to be doing a training on SBIRT, which is a brief screening and intervention process, as well as talking to us about motivational interviewing, and as well homicidal and suicidal ideation in a treatment setting. So that's going to be providing CEUs as well. If you are looking to get SBIRT trained, this is completely free. So I will have a flyer out hopefully shortly with registration links and things like that. But we would love to have you there with us so you can get that free training. All right, my housekeeping stuff is out of the way. I'm going to stop my share here. So we are going to get to the presentation. So I want to talk a little bit about why I wanted to pick this particular topic, which we are talking about esketamine for therapeutics and mental health challenges. If you're like me driving around listening to the radio, you may hear commercials for ketamine as a treatment option. So I first started hearing these a couple of years ago. And I was curious back then, and I've only seen it grow since then. We've previously had presentations by folks like Bruce Seawick at College DuPage talking about having options like psychedelics and psilocybin mushrooms as a treatment option coming up. It really is an expanding and growing part of therapeutics and the treatment process. And I think it's an option that can help a lot of people as well. And so Geode Health and Kylie Senko in particular has been a great friend to ROSC since we started pretty much. In our ROSC WhatsApp referral chat, she's been amazingly active. She was our MVP in there last month. And so we were glad to be able to connect with her to bring us a presenter to talk about these esketamine treatments that they offer at Geode Health. So we have a great presenter today, Chibogu Obianwu. Okay, I said it right. Okay, I didn't butcher it. I was
Yes, you did. Yeah, yeah. Thank you, thank you.
She's a psychiatric nurse practitioner at Geode Health, and I'm glad we could have her here with us today to talk about these treatments. And we will have some time, hopefully, for some discussion and questions at the end, because I think this is a great topic to have discussions about, because it is one of those kind of newer options for treatment. And so let's see what's available and what Geode has on offer for us. So I'm going to go ahead and turn it over to you, and let's learn more about esketamine.
Cool. Can everybody see my screen? Is it good? Okay, cool.
Yes.
Yeah, so really quickly, I feel like most of you guys are kind of familiar with Geode, especially if you're in the group chat, but we do all outpatient therapy. So we can do therapy, psychiatry, medication management, TMS, we do Spravato, which you'll hear about a little bit more today. So we have about 17 locations around the Chicagoland. And yeah, I would love to connect with you guys. I put my information in the chat. So feel free to reach out if you have any additional questions just about Geode or Spravato. I can get you in touch with Chi after she's done. However it is, I would love to be a resource for you guys. So Chi, take it away.
Hi, everyone. Thank you so much for joining us today to speak about Spravato, since it is evolving treatment. So I am happy that you all are here, and definitely feel free to ask questions when we're done with the presentation. I'll keep it short and concise. So Kylie, please, could you share the first? Thank you. And yeah, we do the Spravato treatment under the supervision of Dr. Bekowitz, who's not here today, and he really expresses his sincere apologies, but we're here to answer any questions you may have after the presentation. All right, so Spravato. So first of all, I want to just kind of touch on the overview of Spravato as a treatment. Spravato is FDA approved for treatment-resistant depression and also major depressive disorder, especially with people that present with suicidal ideation. Spravato was FDA approved, I believe, in 2019, and since then it's been evolving. It is categorized as Schedule 3 nasal spray, also known as esketamine. And Schedule 3 just means that it's a controlled substance because it has the potential for abuse, dependency, and misuse. It is mostly used for in conjunction with someone that's taking a traditional antidepressant. So it is considered an adjunctive therapy, meaning that you add it to the traditional medication that the patient is taking. So that's one of the major things that insurance will look for, is that the person is still taking their medication as well as utilizing Spravato. Next slide. All right, so the Spravato, how do we know that Spravato is the right treatment for patients? So what for the approval odds, it mostly depends on the insurance, but for the most part, they'll be looking for the diagnosis of treatment-resistant depression or major depressive disorder with acute suicidal ideation or behavior. So treatment-resistant depression will mean that the patient has tried about 2 or more traditional medication antidepressants for at least 8 weeks, preferably from 2 different classes of antidepressants, and has failed. And also a patient that presents with acute suicidal ideation, though that this is kind of tricky because when someone has acute suicidal ideation, we always tell them go to acute care, meaning the hospital, emergency services first, but it is also approved for that treatment. The patient must be 18 years or older. Another thing I'll also touch a little bit that we don't have here is the contraindication. So some people will come in and they have more questions about what will not qualify me for Spravato treatment. One thing is that the patient should not be pregnant. And number 2, the patient should not have any aneurysm, any history of uncontrolled high blood pressure, for example, any heart conditions that will predispose them to adverse events. And another one that we haven't based on it, but that could also be indicative of the person that has tried treatment and it has not worked, is if they've tried psychotherapy and it hasn't worked for many years, that could also be a potential a potential candidate for using Spravato treatment. So if you ever believe, based on what the criteria that we shared here, that your patient will benefit from this, please don't hesitate to refer the patient to us. We have other things that we have to go over, and hopefully at the end I can answer those questions. So what are the benefits of Spravato, right? So I get these questions a lot because I mean, a patient that's tried for many, many years, right? And they've tried all the medications they could remember that's available, and they still don't get the improvement that they need. So the first one is that Spravato improves mood regulation. Of course, that's what we're looking for, is the mood regulation to be improved. And I'll come back to that. Spravato is also fast acting and effective. So when we prescribe medications, we give the patients instructions that they should have an open mind that medication will take about 4 to 6 weeks to establish efficacy. It does sound like it's not a long time, but it could be a long time for someone who is looking for relief. Spravato with some patients, you know, some depending again is based on individuals, but we've seen people report that the first 2 to 4 treatments, they already started noticing some type of relief. So that is considered fast acting. It increases brain activity. So Spravato is, I'm gonna kind of go through this because it's very important. I always point it out to patients because they say, what makes it very different from the medication? So the mechanism of action, based on increasing brain activity as well as uptake and release of beneficial neurotransmitters. So most of the medications that we use are mostly targeting the neurotransmitters, which is the serotonin, norepinephrine, dopamine, and other ones sometimes GABA, glutamate. But the main difference for between the Spravato treatment versus traditional antidepressants will be that Spravato not only does it target neurotransmitter, especially glutamate, but it also targets the neuroplasticity of the brain. So with is considered, so Spravato is considered NMDA receptor antagonist. So what it does, it stops the NMDA receptors and the GABA receptors. In exchange to that, because GABA inhibits the release of glutamate, once it inhibits that receptor in the GABA, then glutamate is released. So glutamate is known to help with memory issues, you know, improving cognition and mood. So that's one way it works when it comes to neurotransmitters. Another way it works is the plasticity of the brain. So BDNF, which is just the brain-derived neurotropic factor, it is just a protein in the brain that helps with kind of renewing the nerves in the brain, so to say. So that these changes have been found to help significantly when it comes to mood symptoms. So this is one benefit that Spravato has over traditional medication. Not only does it target the neurotransmitters, it also helps with, you know, renewing the brain structures. So that is one thing that patients are glad to hear because they want to know the difference between, you know, the sacrifice they're going to make and how it's going to help them. Next slide. Okay. All right. So in conjunction, I also want to add a few things here because though we covered just a very concise information when it comes to Spravato, I get the question of what does it entail when I come to do Spravato? This is what your patient will have to do. Basically, Spravato treatment, we schedule patient Spravato consults, which takes about between 45 and 60 minutes. We talk to the patient, get a detailed assessment from the patient, and also their records if we could. Then we submit this information to insurance, and then we hopefully, based on the screening and assessment that we gathered, that insurance will approve. It does take about 2 weeks, approximately, to have hear back from insurance, so 1 to 2 weeks. And then we end up contacting the patient if they approve it, and then we go from there. So the first treatment, the first scheduling of the treatment, we want to make sure that the patient has someone that will bring them to the center and then take them back since they will not be able to drive. Spravato is a psychedelic, so it can cause some, like feelings of drowsiness, somnolence, and it's just like, think about it as a mini anesthesia. So you wouldn't want the person to drive because they may still be drowsy by the time the treatment is over. So that is one thing that is required. Another thing is that the patient also will have to come in and be able to have about 2.5 hours in the clinic. The first treatment for the first month will be 2 times in the week, in a month, sorry. So, 2 times in a week for a month. And after that, they go down to once a week for another month. And then it goes down from there, depending on how they are reacting to the treatment. So that is just a ballpark of how the treatment works. Please, if you have any questions, I'm open to answer. Thank you.
Yeah, thank you. I have quite a few questions actually. So the first one, so you said when you were talking about the criteria for at least at the very least like insurance accepting it, but just kind of getting onto the treatment. You said so two or more antidepressants or therapeutics has failed. What's the like criteria for like quote unquote failure? So is that like a self-report failure, or is that in conjunction like with a psychiatrist referral? What does that look like for like 2 or more failure?
Okay, great question. So 2 or more failure, for the most part, we love to get the records from the patient's provider, but it could also be self-reported. So what we base it on is 2 or more failures of antidepressants will be at least trying one for at least 8 weeks. And then maybe trying another from a different class for at least 8 weeks. That will be considered a long enough trial of 2 antidepressants. So we have patients who self-report, that's okay. Because insurance will have their information for the most part. And we love to support that by getting their records from their provider if they have it available.
Then the other question I have is, what are there any like other medications that maybe the patients like shouldn't be on or have like any type of like adverse reaction if it's combined with something?
So this is kind of a case-by-case basis because it's not a blanket, but obviously when we see the patients, we are looking for the reason why they're on medication, more so of the medication that they're taking. So for someone like that is taking a blood thinner, we want to know why you're taking the blood thinner, because it might be it might be a different condition based on the disqualification. One of them is no known aneurysm or any heart conditions. Or so if someone is taking a blood thinner because they had a blood clot many years ago, then we will not do that. We will not like exclude them from getting this Spravato. But for the most part, it's on a case-by-case basis. I don't know exactly what medication per se that patients should never be on. But at the same time, there are medications that we also tell patients not to take the day of treatment. Something like a stimulant because of increase in blood pressure can happen with that. So we tell them to hold it. If we have questions about a particular medication, we try to reach out to the Spravato reps who reach out to their clinical consultants and answer the questions for them.
And then the other question I have is, so I've seen personally, things like medication-assisted recovery, medication-assisted treatment really kind of changed since when it first started. So for instance, like when we're talking about MAC clinics, so like Suboxone and some of the other treatments like that for opioid use disorder, really when it first started, a lot of it was just kind of distributing the medication itself. And then over time, they really have like obviously partnered it with therapeutics. So if someone is on esketamine treatment, what is the partnering up with like the therapeutics look like? Or if they're taking it, do they meet with a psychiatrist a certain amount of times? What does that look like if someone goes onto this treatment?
I'm sorry, just to clarify, are you asking about the treatment for Spravato?
Yes,
partnering?
yeah. So if they start, taking esketamine or Spravato, are they meeting with the psychiatrist as well as, you know, when they come for their treatment? What is, you know, what's that option look like?
Oh, okay. Yeah. So most of the patients that coming from are referred by their providers, meaning their psychiatrist or advanced practice nurse or physician assistant. So basically they're referred by someone who's been taking care of them for the most part, but there are also some others who just walk in, you know, like somebody just told them about us. So usually the ones that we have for the most part will have someone established that is managing their medication while we're just doing this private treatment. We've also had a couple of our patients who we have as ours, we're managing their medication. So we're partnering with them as well as administering this private treatment. So it just depends on the patient condition. But for the most part, they have their own site providers that manages their medication and other treatments. We just focus on this provider.
Okay, and I had one more question, then I'll open it up for anybody else that has questions about it. But what's the timetable look like? Is this a treatment that someone, you know, is going to be on for, you know, the rest of their life? Is it something where they kind of, you know, maybe it helps them get through a certain period and then they, you know, maybe decide to wean off? I mean, I'm sure there's a case-by-case basis there too, but ideally, is this supposed to be a treatment that just continues for the rest of their life?
Oh, very good question. I like that. So, okay. So, so this question has been asked many times. Yes. So the first time, I would say the first couple of months will be a bit of like steady timetable. So they come in the first month, like I said, they do 2 treatments a week for the first month and then drop down to 1. And then they can drop down to like every other week, sometimes every month, depending. But what we're looking for is actually we're assessing to see how they're feeling, right? That's the major goal, is to make sure that they're feeling better. And then how better are they feeling? So we have the PHQ-9, which we use to assess each visit, and as well as the subjective report that the patient gives us. We say, you know, this is just an advice because it depends on everyone. We had people who had stopped just because they feel better or they can keep up. But for the most part, we always encourage patients to, you know, don't drop off completely, except if you're feeling like, okay, I feel good. You can definitely drop off. It's not an eternal type of treatment. But the problem sometimes that people tend to face is that when you drop off and then hopefully not, but then something happens in life that triggers another depressive episode, insurance might kick back at that point, right? So we tell people, even if you have to, you can do once every couple of months, something just not dropping off. But for the most part, if the person says, because you know, all medications carry side effects and stuff. If the person says, I don't think I need it at this time, definitely, yes. The main goal here is to make sure that the patient is able to function in life and that they feel better. They have some type of relief from their symptoms. So it is not meant to be continued for, you know, for a long period of time and indefinitely, if I may say that. But at the same time, it can benefit them because insurance may kick back if they try to come back again to do it.
Great. Well, I'm going to open it up. I actually have a couple more questions, but I'm going to give other people a chance to ask some stuff if they have questions for you. So first of all, thank you again for presenting on that.
Thank you.
If anybody has a question, you can put up your little digital hand, and I'd be happy to put you up here, or you can just unmute and jump on.
Hi, Chibogu. Thank you. I appreciate your presentation and answering the questions. You and Jared kind of combined asked and answered my last question, but I guess I wanted a little further clarification. So I know you mentioned the multiple episodes, right? And what happens if, you know, the first episode they were there for, Spravato helped out, you know, then life happens, a couple months goes by, and it's a whole new depressive episode, right? It's a new cause of depression, not related to the initial one. Do they have to go through all of that screening again to make sure that Spravato is the cure? Like, I know that Spravato may not be medically necessary at that point or approved by insurance, but as part of getting approved by insurance, saying, hey, I need to go meet with a therapist for an extended period of time again, or I need to try 2 more medication trials. you can clarify.
Great question. Yes. Yeah. Thankfully, we haven't gotten to that point yet where someone, because we started about a year ago. So for the most part, just by the reasoning, when someone has a depressive episode, I'll say if we did see the person like a year ago and they had treatment for say 3, 4, 5 months, and then later they come by and say that they have, like they're expressing the same thing. If it's within the year that you had assess them, I wouldn't think that you have to go back again and start over, because usually assessment is yearly, right? And of course, if the person doesn't come back in a year, when you see them after a year, you have to reassess. That's just how we do that in Psych. But if a person comes in within a year, say that we've treated them and then a few months later they come back, I do think that we'll have to have a visit with them, just kind of updating the information, like what has happened, and then of course submit it to insurance. It might not take as long anymore, just because they had that proof that the patient needed this and it had worked at the time they had it. But I'm not going to say, I don't know what the insurance will do based on like approving the odds again, the approval odds again, but we would not have to go over because we already have the records.
All right. But if anybody else has a question, you can put up your hand. I can put you up here. In the meantime, I have another question. Full disclosure, I'm not clinical, so this may sound like a silly question, but has anyone ever approached y'all for esketamine services to treat anything like substance use related? Is it all just for like mental health, like specifically like depressive episodes? Sometimes, this might be an option for somebody who's tried a lot of other stuff, specifically for substance use disorder, and maybe thought this could be something that might work for them. Is that something that people have tried, or is it even an option?
Oh, thank you. So I haven't come across someone who has tried to get in just because of substance use disorder. I have come across patients who had comorbid conditions like substance use disorder, but also have major depressive disorder. And most of the time it is because the patient is trying to self-medicate, at some point in life. That's why they have that history. But Spravato is not used for substance use treatment, disorder treatment. It is strictly for mood disorder, specifically for major depressive disorder without psychosis. So I'm yet to come across someone who's reaching for the treatment just specifically for substance use disorder. If we have someone like that, we do either, depending on the treatment that they need, either treat them before, like doing the Spravato, or we can refer them out. But Spravato that we use is mostly for the mood disorder, depression.
Good. So my next comment, I brought this one up at other presentations. I think when we maybe were talking about certain psychedelics as a therapeutic option. I think sometimes the people who could maybe benefit the most from treatment services like this sometimes have the hardest time accessing them due to insurance or other barriers. So my question is, what does this treatment look like for someone who maybe has Medicare or Medicaid? And if it's something that isn't offered, is there anything being done to work towards maybe having that as an option for Medicaid and Medicare at some point?
Good. So we will have to get that answer for you, because I'm not well versed with the insurance part of things. We do not, as Geode, we do not accept Medicaid right now. It's one of the things we're looking to hopefully in the future do, but Medicare, I'm not well versed in that. So we will have to get the answer back to you, okay?
Okay.
But thank you for asking. That's a really good question, because yes, it is. There are some people who really need this treatment, but they're based on insurance, they're not able to. So yes.
Yeah, and I didn't mean to put you on the spot. I know.
No, that's okay.
I like to ask that question for when we talk about, service providers, just because as folks who work with a lot of referrals, and we work with a population who sometimes, obviously, if they have insurance, a lot of times it is Medicare or Medicaid. So we try to have as many options on the table as possible for them. So
Yeah.
we're advocates, so we gotta ask the question.
Yes, I know Medicare is very particular with what is required. We do have like a medical assistant that is does that really get into that, and we could get the answer from them, and then we'll get back to you. But with Medicaid, we don't accept it. Medicare, I know it's a possibility, but there are some things that we need to inform you about that part.
Yeah.
Really quick. We do
yeah.
have Gina on here. I wanted to introduce her really quick, not to totally put you on the spot, Gina, but she's our Spravato medical assistant. Do you know that answer? Totally fine. If you don't, we can still look into it, but I wanted to give you the chance.
So
to.
we can work with the Medicare referrals. And if they have a Medicaid secondary, we can work with that as well. But it would have to be secondary. If you're Medicare dual eligible, you have to be QMB in order for us to accept it. So it's just something we double check if you know insurance. But yeah, super nice to meet everybody. My name is Gina. I'm from Geode Libertyville, and I'm the medical assistant Spravato technician that works with the patients in the office.
Nice to meet you. Thank you for being here. Do you mind me asking, what does QMB stand for? I deal so little with insurance.
Qualified Medicare beneficiary.
I learn new things every day. I appreciate that.
Don't we all? Nice to meet you.
Nice to meet you. My colleague Saleha has a question, it looks like.
Yeah, hi, thank you, Jerry. Thank you so much for all the information so far. It has been super interesting and something that has been like an area of curiosity for me for quite some time now. I had actually a leading question from what Jared had asked, since it was just a thought. So, for example, someone who is trying to access services who does not have, who maybe has Medicaid or doesn't have a qualifying insurance that you will accept, what would, no, this can vary, but what would an average cost for a visit or like treatment like this look like for them? So let's say if they have to elect to pay out of pocket, like I'm just curious as to like what the cost would be to access this this treatment.
Well, thank you for your question. Okay, so because I know it's an expensive medication, right? I know it's expensive, and then of course based on the supplier, the pharmacy, but when you're asking the cost, are you asking for a visit for an assessment or visit for treatments?
Yeah.
As well? Okay.
Sure. Yeah. So visit for assessment, and then also then what would the treatment look like? So let's say if I were to be a prospective patient and I came into the clinic and I was like, well, I have Medicaid and I just need to get an idea of what this would look like financially for myself, what that would look like.
Okay, that makes sense. So for the visit is not, the visit is also based on coding, the way we code things. So if it's just like a consult to see if the person qualifies, we just code it based on the visits, the time. So that would be, just what we charge for a regular visit, like anybody else who doesn't have insurance. Now, when we talk about, like affording to pay out of pocket for Spravato treatment, that is a different case. I know it costs thousands just for one. I cannot tell exactly one, but Gina, if you have any type of, like idea what it will cost ballpark, please answer the question. But I do know that it's very expensive for just one treatment. Yes.
Thank you.
So if I can chime in. So we had this the other day, and the initial Spravato consultation is just the regular billing, right? But then you have these visits for administration, etc. It comes out to about $700 a piece, and then general billing, and like Chi-Chi said, depending on the supplier and the pharmacy, this would change, but we see about $3,500 to $4,000 a month in a medication term. So you're looking insurance-wise for your visit, and then you're also looking at medication costs. So those two things together.
Thank you so much, Gina. That was great. Thank you.
So I'm guessing that the amount of people that you're servicing has probably been growing, right, over the past few years. Is this something that you see just continue to grow as an option? I mean, I know it's still, I hesitate to use the term newer because I'm just using that anecdotally, meaning like I've only started hearing about this over the past couple of years, but are you seeing like more and more people come, you know, specifically for these services?
Yes, yes. So we've been doing this for approximately a year. Yes, it's been growing. I mean, we have room for more. We have room for more, and we want to keep expanding because we know like it works. We know that it's effective. So yes, over the years, not over the years, but over the months, we've seen you know, quite a few, and we continue to see people inquiring, and we're hoping that we keep expanding, you know, with networking and yeah, putting out information out there for people who need it.
Well, thank you. Does anybody else have any questions?
I do, if I may.
Go for it. This is Ben Rudolph, one of the great TAs that helps oversee the ROSC. So Ben, go for it.
Okay.
All right. Well, ketamine and esketamine, are they the same thing?
No, they're not. So ketamine is esketamine is an S isomer, just like think about it like a little part of ketamine. So it has its own chemical components. It's like how would I put it? Like a little sister, like kind of thing, but they're not the same. Yes.
Okay, but they're related.
Some type of relation, yeah, chemically,
Okay.
yes, but they're not the
Question
same.
number 2.
Good question. Good question.
One more.
Mhm.
I wrote down here that Spravato is a psychedelic.
Yes, yes, it is. Is that
Okay.
approved psychedelic?
So when someone comes to treatment, you mentioned that they have to have a ride because they're not going to be able to operate machinery. How
Yes.
long after treatment will they be able to independently live, I guess? I don't know how to say that. So they're not able to drive. They're going to have to let the side effects wear off.
Okay.
How long,
Yeah.
if I took this drug, would I then be able to independently process my life and go to work and do the stuff I need to do?
Yeah, yeah, great question. So yes, we say when the patient finished the treatment, we say the night of, the rest of the day, you know, take it easy, have someone at home, and usually by the next day, the effects are wear off and they continue with their life. So
Okay.
it's something that is transient. So you have a few hours, but to be safe, we say just kind of sleep it off at night, and the next day they feel better. They feel normal for the most part.
Great.
Yeah. Mhm.
Thank you.
Thank you.
So if this is a medication they go on like, you know, regularly, and maybe I missed it, and I'm sorry if you said this already. So say I come in, you know, initial treatment, I have somebody with me that's able to drive me home. When is the next treatment? So could you tell me that part again? So this is kind of piggybacking up what Ben said. So if this is something that I go on regularly or whatever the regular rotation of it is, yeah, how does that affect me being able to drive or work or something like that? After the first one, when is the next one?
Okay, so how we're doing it now is we're doing every other day. That is what is approved. You can't do back-to-back days. So we're doing Tuesdays, Thursdays, hopefully open up Monday, Wednesday, but kind of alternate days. And again, I wanted to mention that they don't have to, like, the main thing is that they shouldn't be driving themselves, but they can take Uber as well, because not everybody has someone available to be driving them around. So yeah, the option Monday, Wednesday versus Tuesday, Thursday, or things like that, that is acceptable as long as it's not back-to-back days. And then just remember that the first month is the back to the Monday, Wednesday, Tuesday, Thursday kind of alternate days, and then it drops down to once weekly. However, there are some people who don't get the relief they need, or they end up, you know, like a couple of months later, they have a hard time, or they reach a plateau where it's not really working, and they can go back to twice a week, you know, just as needed. So it's kind of flexible. Yeah.
Okay. Any other questions? In the meantime, what's the best way to get started on this if someone wanted to do this? Is it an assessment process? Walk us through that so we can pass this on, you know, if we
Yeah.
get referrals for someone looking for something like this.
Yes, absolutely. Thank you. So I shared, Kylie is going to share the number on the screen. That is our Spravato direct line. So if someone is, for the most part, people are referred by their providers, but say someone just kind of wanted to reach out on their own, which is great as well. They can call this Spravato line, which Kylie will share. And that will be Gina. Gina will, ask them a few questions, just the screening questions to kind of make sure that they don't have those criteria that I mentioned. And if they qualify based on that, then she'll schedule them with either myself or Dr. Bekowitz. We will have a consult for about 60 minutes in person in Libertyville. After that, then that's where we gather the assessments, their history, as well as the PHQ-9, things to support that they are really struggling. And then we gather those information. Gina will work on putting them through insurance, and then it takes about 1 to 2 weeks, depending on insurance, to hear back from them. And then if they qualify, if they're eligible, then she'll, I believe, enroll them in REMS, right? Or you enroll them in, REMS, and then we work with the patient to start the treatment.
Okay, and I'll share that with everybody, and I can share that with other ROSC members. Last question, I promise, for me. I know it hit you.
Oh, no, that's fine. I'm here for questions.
What would you say to someone, because I'm sure, in talking to people in previous presentations about, psychedelics for this stuff, or, specific, different harm reduction related approaches, there's clearly still stigmas attached to these types of treatments. So what would you say to somebody who does have, maybe a stigma towards this, or says like, this is, this psychedelics, what would you say to people who maybe still have stigma attached to these types of treatments, as far as like what you've seen for success rates and stuff like that?
Oh, that's great. So what I say to people is like, mental health is already surrounded by stigma, right? So here we're gonna think about our goal. Our goal here is to bring you relief, to be able to function in life. Okay, so let's remove the association of what is it that it's meaning to other people, and focus more on how we're going to get you there. So the person has obviously been through multiple treatments, and for them to be able to be willing to try something different, with those kind of stigma or side effects or things like that, means that they really need help and they want to get the help. This has been FDA approved. So what it means in America for something to be FDA. It's gone through a lot of scrutiny, clinical trials over and over again. So for it to be approved means that they know that it works. It's been proven, right? So we're going to focus on the goal of not thinking about the negative implication of what others think about what is associated with the Spravato. We're going to focus on the positive, being that it not only, like I said, does what the traditional ones do with the neurotransmitters, it's also working on the structure of the brain, because during the clinical trials, they have found out that people that have gone through long suffering of depressive episodes, have some type of clinical, some structural brain differences, right? So if it's offering that, which is, let's not continue to do the same thing and expect different results. Let's try to do something else to expect different results. At least let's try. So definitely I will tell them to not focus on the negative, because we are also making sure that the patient is not using controls, not control something, that's not what I meant, but not using substance use, don't have active substance use disorder going on, because we don't want to be encouraging that. It does have potential for dependency. So we do a urine drug screen every week when they come in to rule that out, to make sure that we are actually focusing on what needs to be focused on as well, instead of feeding off of what they're suffering from. Yes, so definitely, I know that it's a lot of stigma when it comes to psychedelics, but we're doing it the right way. This has been approved. This has been proven to work.
Celia, you got another question?
Yeah, so for doing urine screens for every time a patient comes in, if someone tests positive for other substance use, are they then referred out, or are they denied treatment just that day and asked to return back for treatment at a later time, or how does that process work?
Okay, good question. So yes, so if the patient comes in and we do a urine drug screen and is testing for something that they are not being prescribed, because some of them would test positive for something like pain medication, because it's prescribed, so it's not. Otherwise, if it's something showing up, we haven't had that happen, but if it's something showing up that is not there, we will have to investigate some more. We will talk to the patient. How did this get here? Because sometimes you have false positive for, some metabolites, something else, medication will be testing something. So we will also order like what's called a comprehensive urine drug screen. So confirmatory, we're gonna do that to confirm exactly what it is. They break it down. And from there, if we see that the patient is testing positive, still for something in particular that is not being prescribed, then we will definitely either refer out, stop the treatment of Spravato, deal with what's the issue at hand, and maybe circle back later. We are yet to experience that, but that is what my clinical judgment would tell me to do. Yeah.
Thank you so much.
Yeah, no problem. And definitely we will not give treatment that day if that happens. Yeah.
All right. Any last questions from anybody?
So guys, I just wanted to chime in really quick, that awesome question about what is the difference between ketamine and esketamine. I have some good education on this. So, why, like, going to an IV ketamine clinic versus like a Geode clinic for nasal administration. What I found out is that IV ketamine will absorb for the patient in just one side of the brain. Now, esketamine has an additional protein added to it, to where when you are administering nasally, we're working with the left and right side of the brain. So that's one of the big differences in those two scenarios. So I just kind of wanted to mention that.
Yeah, thank you for making that distinction.
Thank you, Gina.
That was
Thank
really
you for
helpful.
Yeah, absolutely.
That was really helpful. Well, Chibogu, Chichi, I feel like we're friends now. I can call you Chichi.
You can call me Chichi.
For the presentation. We really, really appreciate it. And thank you to and Gina and Kylie for being on the call too. We really appreciate it. We'll share all this information with the people who came. And don't be surprised if we try to refer someone to you at some point.
Yes, please. Yes, that's
these types of services are always needed and helpful. So thank you again to everybody for coming. And we'll put up this video on YouTube hopefully later today so you can share it with whoever else wasn't able to make it. And we will see you at the next one. Thank you again, everybody.
Thank you.
Bye, guys. Thank you.
Bye.